So it's week 8 already. This week was the week of reviews. If you look at your announcements, all the reviews have been posted. As I said, whatever or whoever wants reviews next week, just let me know. Give me a day and a time, and I'll work around you if I'm not teaching or have something else. So anybody who wants to join that Thursday group, no problem. The more, the merrier. So week 8, there's a lot of chapters, a lot of stuff. GU, skin, metabolic, communicable diseases, and natural disasters. And there's a lot of information there. There's a lot of slides. And there's also a cahoots that, will accompany it. I will try to go as far as my voice lets me go. I'm sitting here sipping on some tea. It does have honey in it, so thank you. Yes, that's what I do. My husband made me a whole bucket of it, as we call it, in a big thing, and just keep me sipping. So let's go ahead. Let's start with our PowerPoint. I did the review, and quite a few people came. So please make sure you listen to it and get yourself prepared before you come and meet me. And then you're going to have questions, and I can help you answer them or make it clearer. So let's start with GU. So GU, how do we look at GU and how do we know it's functioning? Well, a simple urinary, specimen, a urinalysis, that starts it out. And we can look at what's in it. Are they the right things or the wrong things, right? Then if we're having problems, of course, ultrasounds, IVP or IV pilogram, I use them a lot when we have kidney stones, more in the older patient, believe it or not. I've not seen them in the young ones. CAT scan of the kidneys, looking at function, what does it look like, looking tumors, of course, biopsies, and a kidney biopsy could be due to tumor or it could be due to persistent urinary tract infections. It could be something in the kidney that's harboring bacteria that we're not killing. We're looking at the flow. We're going to look at inside with a scope. And then one of the things we do in children to look at structural things is avoiding cystourethropy. And what they do, it's an outpatient procedure under x-ray where they put a Foley catheter in and they put dye in and then clamp it. And then they see if there's any refluxing going on there or looking for any structural problems with it. And then they let all the dye out and see maybe there's residual dye there. So there's a lot of different things and testings that we can look at. So urinary function, what are those vocabulary words? Anything with a dis is difficulty or painful. Dysuria, painful urination. Frequency, you're going a lot. Urgency is like all of a sudden you got to go and you better run now because you might be incontinent. Nocturia or enuresis is urinating at night. Polyuria is a lot of urinating. And oliguria is when you stop urinating, like as in kidney failure. So one of the abnormalities of the urinary tract infection, and this was Christian at birth. I firmly believe in pulling down the foreskin of the penis and cleaning underneath every day because that's how young males that are uncircumcised will be more apt to get urinary tract infections. Well, I couldn't pull it down. I mean, it was very tight. So we ended up getting him circumcised, not for cosmetic, but because if you can't pull it down, there's going to be that schmegma that builds up underneath. It's like a petri dish. And then, of course, infection. So phimosis is that tightening. You cannot pull it down. Now, hypospadias, epispadias, Sometimes these are accompanied with a syndrome, like the George syndrome, like Pierre-Robin syndrome. It's one of those things that could happen with it. So what is it? Well, the the urine usually comes out through the urethra at the tip of the penis. With epispadias, it comes out the top somewhere, not a certain place, but nothing out the tip, but somewhere on top. And hypospadias is somewhere on the bottom. Now, if it's almost there, they're not going to do anything. But many of them are quite significant where they're urinating out of. We do like to do this before potty training. What they do very seriously is they open and fillet open the penis, create a canal, and then they put a catheter, like that picture on the bottom, put a catheter in there, and then that urethra, that whole opening is formed. We have to have the skin from the foreskin. We need that for that closure. So these children may not be circumcised if we're going to be doing one of these repairs. And what do we do with that catheter after surgery, after they have it fixed? Nothing. We make sure it's inside the diaper so it's not urinating everywhere. And then the surgeon takes it out 7 to 10 days. Now, extrophy of the bladder. Sometimes the body doesn't close up, and then sometimes the insides are left out. Now they're working. There is like the bladder is connected to the ureters, yeah, to the urethra, and the ureters and the kidneys are there. It's all okay, but the bladder is up on the outside. Is what we call a midline not closure of it. Now, one of the things we have to be careful of is that there could be some irritation on the skin. So we really need to protect that. And it's exposed, so infection, right? Worry about it. Make sure that we keep diapers under it to collect whatever fluid comes out. And these children should be on their back. They don't lay on this bladder. That would allow it to be squished. It wouldn't work. And we fix this pretty quick because we don't want the bladder out there drying out, being exposed, to the air, into infections, and then of course you're in overwhelming sepsis. So we try to do it quick. Now, I've mentioned a couple times about there could be obstructive uropathy, whether a kink in the ureter, maybe one of the valves is not working right. And all of these things can cause backflow up into the kidneys if the urine can't come down because a ureter's kinked. So the urine's drying, but there's no opening. Could be one side or both sides. It's going to go back up into the kidneys, causing hydronephrosis, water on the kidney, basically. Um, we know that sometimes we need to do surgery, polycystic kidneys and whatnot, and we really need to do this surgery again before they're potty trained, okay? Sometimes with this obstructive uropathy, they need to have a urostomy. It's like a colostomy, but the ureter comes up to the abdominal wall. So this, when they do it, it's to get the kidneys flowing and protect the kidneys from dying. Now, what they do later on is they take this ureter and they'll connect it sometimes down into the rectum because that body esteem, adolescence, having that bag for urine can be a big thing, whether it's esteem or sexuality, it's all those things those kids are going through. So obstructive uropathy, it doesn't work, but they still got to get that urine out or it will kill the kidneys. So the parents of a 4-year-old boy explained to the clinic nurse that for weeks the child's been irritable and listless. He's even developed a poor appetite and he's gained weight. What signs and symptoms should the nurse look for? And what conditions should the nurse suspect? What interventions? Now, as I said, below these things, why did it do that way? There is a underneath, you will always find a little bit of what's going on, and it gives you those answers. So if you haven't figured it out, I'm showing you again. So a 4-year-old is not urinating. He's gained weight and irritable. Well, if you're gaining weight and they're not urinating, where is that fluid going, right? And what this probably is something called nephrotic syndrome. Now, nephrotic syndrome is not kidney failure. Nephrotic syndrome is the kidney saying, proteins, I don't like you, and let me get rid of you, and it spills out into the urine. And remember, protein is also called albumin, which is in the blood. So it gets rid of a lot of protein. Now, what would you see in these children? Well, if they're going to be swollen, they're going to be, usually their eyes, even their mouth and their cheeks can get swollen. That's why they don't want to eat because usually they're chewing on their tongue or chewing on their cheeks, and it gets to be the point of being painful. What they do is with these children, and as nurses, we need to do the treatment, usually steroids, and we need to figure out, well, is it working? Well, these children will be on fluid restriction, salt restriction, given the steroids to treat it, and we'll be monitoring intake, output, and daily weights. Whenever you talk about anything to do with fluids, what you're going to, monitoring it is intake, output, daily weights from whatever it is. So that's what that question was talking about. And what interventions again is making sure fluid restrictions and being careful with salt intake and of course monitoring their weight at home. Now, urinary tract infections very common in girls and those young boys like, uncircumcised, less than 6 months old, usually they say. Now, girls have a very short, wide open urethra. And what do little girls and boys love to do? Even my grandson, who's 7, taking bubble baths, right? That's a really neat thing to do. But they sit in the water with this whatever perfume type of bubbles and all of the dirt that came off their body. And it goes up and it can create vaginitis and can go up into the bladder, can cause infections. Now, most of the time, urinary tract infections are E. coli. It has to do with the positioning of the anus and the urethra, right? It's that wiping the wrong way. And young kids, they're going to wipe the wrong ways. They're not going to, oh, let me wipe front to back. No, they get hurried in a rush and they go, right? And when they don't get it all or do the wrong way, urinary tract infections. Now, what is the kid going to look like? Well, an infant can't really tell you. The only thing you could see is maybe a fever if they got it, and maybe the smell of the urine. Older children, you're going to see maybe that frequency, that urgency, and maybe the color, or of course, even the smell you might see. So infants, because they don't have a great immune system, usually will be admitted for IV antibiotics. Older kids already have an immune system. It's not as, worrisome to let them go home with oral antibiotics. So the difference is IV PO is their immune system. Children under 1 don't have it as much as we'd like it, and we're just protecting them. Always remember, children, that we need to encourage fluids. That's the big thing with these children. Increase fluids, getting them flushing it out. Again, teaching to wipe front to back, avoiding bubble baths. Today they love those tights, those nylon stretchy tights. They look so cute on these girls. But that and polyester cute underwears that are frozen underwear or whatever, it doesn't let the perineal area breathe. Ideally, white cotton underwear is the best choice for children, girls especially, and pants that are not so tight that it doesn't allow it to breathe. And then always increase fluid. Make sure they're drinking. Now, that nephrotic syndrome we were just talking about, right? Let's go into it a little bit more. It's more in boys than it is in girls. It's that 2 to 7, and it has to do with some T cell something, immune system. So, immune system problems, okay, now we're going to be more apt to get infections, more immunosuppressed. That's one thing. Good hand washing, we're going to teach. And you see the way his eyes and all of that look swollen, even his lips, is generalized edema. And one of the ways that we at home will teach our parents, they're not going to measure intake and output. They just don't get that like a nurse does. We're a little OCD with that, not at home. It's the weight on the same scale, same time every morning before breakfast is the best time. If we start seeing them getting pale, irritable, listless, you stop eating, this is when you really need to get them in for care. One of the things with nephrotic, even though they're gaining all this fluid, and many times we would be concerned about hypertension, not necessarily with nephrotic syndrome. Usually it's pretty normal. So what would you see in the urine? Well, proteinuria, massive amounts. And again, these children are apt to get infections because of this T cell dysfunction thing. Again, we give steroids, and you've got to be careful with steroids. Steroids is a lot of things, right? Mass signs of infections, it can cause swelling. It could be wound delay and healing. So you got to be careful with it. Give it as you're ordered. Again, with this condition and all this swelling, you're like, well, just give some, diuretic. It doesn't work. Actually, you have to put the protein back in the blood and give a diuretic to pull it out. Yes, Tamara. Sorry, I just saw you.
No, it's fine. What is listless?
Irritable, just moving, not knowing what you want to do. You're listless. You're antsy.
Okay.
Okay?
Hmm.
Yeah, it's one of those words. I know. All these crazy words we use, right? And it's, you don't hear them all the time. So no decreasing fluids and no adding salt, and be careful with salt in the foods, right? Again, fluid. How does a nurse monitor it? Number one, daily weights. And in the hospital, we actually have our scales numbered because you know that there is a scale that weighs you really good. And of course, the doctor office is always 10 pounds more, right? Well, in the hospital, you will have scales that weigh a little bit differently. So to be accurate, same scale, same time every day. And we know if we're increasing weight, your fluids are going up too. We need to monitor the protein in the urine and in the blood. Now, with all this swelling, we need to immobilize it, right? So you got to keep them moving, ambulating. If they're on bed rest, doing leg exercises, arm exercises, right? That'll keep fluid moving. Of course, I know in the hospital we can do that well. As I said, they're immunosuppressed. You've got to protect them from infections. And at the time of these crises, those immunizations will be delayed because of the immunosuppressed condition they're in. Now, we talked about the cardiac, we talked about strep. causing rheumatic fever, right? Well, strep can also affect your kidneys and cause acute glomerulonephritis, which means all of a sudden your kidneys stop urinating. You retain fluids, blood pressure goes up, and it's usually when they stop urinating and then getting headaches from the blood pressure, they go seek care. The last is you had a sore throat in the last month. And when they do, they're going to say, okay, most likely acute glomerulonephritis. Usually, you can clear this up pretty quick. And what do? Well, we give antibiotics, right? We're going to be given the penicillin, and we know that it's going to be given for about 5 years as a prophylactic. Now, an 11-year-old girl's been diagnosed with a urinary tract infection. What key point should the nurse teach the patient and her parents about treatment? Well, what do you know about the treatment? What do we do for urinary tract infections?
Plenty of fluid.
Excellent, excellent. That is always number one. What else do you think besides that?
Um,
Antibiotic.
Antibiotics, make sure they take all of them, right? Not just when you feel better. That's a misnomer. Oh, they don't need any more. Especially younger kids who don't like to take meds. Oh, they're feeling better. Oh, this is such, I can't do this anymore. After 5 days, they stop, right? That's what happens a lot of the time. And then, of course, then prevention, which again, during the acute phase, it's fluids, and then after it's fluids. And then, of course, how to keep it clean, front to back, etc. Good. So, Wilms tumor. Now, I've seen one of these in my lifetime, and I'm going to tell you the story about it. I was working in triage after the Haitian earthquake back in, I think it was 2010, if I'm not mistaken, 2010, 2012, something like that. Our hospital actually went over to Haiti, and our nurses went down there and offered services, and so did the doctors. And they found this little boy. This is, a little Haitian boy who was seen by our crew, and they got this child through a religious group, got them to Miami International, and then another religious group brought him to the ER with a stack of medical records. So I said to the people who brought him to me, I'm in triage. And I said, so why is he here? And they go, we don't know. We were just told to pick him up and drop him off here in the ER. Here's the papers. Well, they were in French, so I couldn't even read it. So now I have to do an assessment, right? So how do you get on the level of a 3-year-old boy who doesn't speak your language? Well, I sat below him. I gave him a sticker. I pinched his little cheek. I talked to him nicely. I knew a couple French words. We giggled. And then I did the assessment with him. I did it. All the vital signs, the temperature, I took a blood pressure. I listened to his chest, and then I listened to his abdomen. And on the left lower quadrant was at least a baseball size round tumor lump. I was like, and for some reason, I knew it was a Wilms tumor. Never saw it before. It's one of those little pieces of information that sticks in there somewhere. And then when you see it, it's like lights go off. Well, a Wilms tumor is a tumor from the kidneys, and it is extremely cancerous and it's very fragile. Just the manipulation, touching, and assessing it can break little tiny pieces off and metastasize in the abdomen. So we do not touch these abdomens once we know that. When we change the diaper, we are very, very careful. So what did they do? Of course, we knitted this child. We did the ultrasound, CAT scans, IVP sometimes to look for the tissue. Because it's kidney, we were watching for hypertension on these children. We don't even do a biopsy before surgery because that will place a little hole in that tumor and create metastasis. So they might do radiation, they might do a little chemo, and then they'll take out that tumor. This child did well. We send him back to Haiti. The biggest nursing responsibility is do not palpate that abdomen. We don't want anything breaking off in there. So that's your Wilms tumor. And my little boy did not have a huge belly. So how I found that, I don't know. I guess he was being watched over from a power bigger than me because it was exactly what it was. Now, hydrocele. Hydro is water. The seal means there's excess of fluid around the sac and the testicles. It causes pain. Sometimes it causes incontinence. So that's water in the testicle. They treat it with usually a shot of Rocephin, believe it or not, and that usually clears it up. Cryptorchidism is when you have a male little baby, you go to the pediatrician first visit. What do? Well, they check the hips, of course, but then they check the testicles. Are they in the sac? The best way to check these testicles is when it's warm. Now, if it's cold in the room, you remove the diaper to check testicles, those testicles will suck up. That's just what they do. If it's warm, they will hang lower, so you'll get a more accurate examination. So, warm room, checking the testicles, making sure that they're there what they need to be. Sometimes you have one or two that are up. If we leave them there, the inside of the abdomen's too hot, so they'll become sterile. So it's important that we do correct this, when we're supposed to. Sometimes you see a hernia with this one, and a lot of problems. If we don't catch this and get those testicles down, the testes do secrete hormones, and we need them to be there on these children. So, with cryptorchidism, sometimes we're going to do that hormone therapy to try to get them down there so that we can make this male that is going to be able to have children when he grows up. Okay? Now, orchiplexy improves the condition and fertility rate. Also, that means a fixing of the testicles, making sure where they need to be. Postoperatively, you've manipulated the testicles. They're in a sac. What they do is they put a scrotal support, and actually, when you're laying, they sort of hold it up so they're not going to swell, okay? We have to protect that suture line. Remember, this is by the urine and the stool. So keeping it clean as they grow, just like women do breast examinations, men should be doing testicular and even young kids just to make sure, especially if they had a problem and needed surgery, when they were younger, okay? Now, young children, we try to figure this out before potty training and being aware of body parts and getting self-conscious about their private areas. So we try to do it before that. It's not always possible. So you can see this where that support, that the private parts can be very embarrassing, and let this child know that his penis is not going anywhere. All they're doing is putting that little thing in the sack. That's it. You see what I'm saying? Because, remember, mutilation, all these things preschoolers are into. So we need to remember that and tell these children it's okay. Your testicles okay. You can call it whatever name that child wants to call it, and just say, we just got to make sure it's where it should be. Now, urinary or genital surgery on growth and development, basically what I've just started talking about. You know, when children become preschoolers, they're aware that there's boys and there's girls. And it starts because of potty training. Watching mommy go to bathroom if they're a boy, saying, "Why do they sit down and I stand up?" And daddy's standing up and he has a body part mommy doesn't have. They start getting very, very, very curious about it. Okay. And we also know that they become very curious and they explore their own parts. And actually, preschoolers is that time where they start touching themselves and even might masturbate. It is normal when we have children touching themselves. um Christian, I mean, I'm going to give it up for Christian. He'll sit there and touch himself. I'm like, Christian, could you please go in the bedroom or the bathroom and touch your penis there? I don't need to see that. That's private. It's okay, go ahead. So I don't make it a big deal, and that's the way it should be done. And they're not going to be self-conscious. Okay. If they need surgery down there or something, again, it needs to be treated the same sort of way, where let them know that the penis isn't going anywhere. This is what we're going to do. And they don't need to feel self-conscious about their body parts. So here we are, routine monitoring 6-year-old child who underwent surgery 24 hours earlier, and the nurse notes a temperature of 102. What should the nurse suspect and what interventions are appropriate? Here we are. So, irritable and listless. And why did I go back to the same one? There we are. My computer's having a mind of its own today. So, all right, he had renal surgery. Whenever he had surgery and have a fever, it is something that we need to look for and figure out what's going on, right? So,
Infection,
oh, absolutely. What else would you look for? How do you see infection?
like the lab work is one way.
How about the
Check the
color of the urine?
incision and the
Yeah, there you
redness.
go. There
Look
you
for
go.
drainage.
There. And looking at the urine too, right? All of those things we're looking at. And renal surgery is usually in the back. What does the abdomen look like? Is it distended? I mean, there's so many things just by looking you can tell. So it's something, 102 fever. Sometimes there is normal to have a little bit of fevers after surgery. Sometimes not. So we always will tell, the nurse in charge, got the doctor, let them know what's going on. Yes, they'll probably do a CBC. When you have a fever elevated post-surgery, most likely the white blood cells will be elevated. And we're going to make sure if they can eat and drink, any child with a fever, we're going to give little sips of fluids, right? We need to replace all of that extra water loss due to that fever. So there are a lot of different things that we can do. Good. My computer will be nice to me. Now, skin conditions. Children are always getting something on their skin, right? So let's look at them. The skin protects our body, right? It is a great, body system, and it prevents stuff to go right into the body. It also protects it from burn. It protects it from, chemical, burning them. Um, so it has to go deeper with it. It does prevent water and electrolytes. And the great thing, it does come back. It does regenerate. Now, sometimes skin conditions could be a systemic disease and some could be congenital. There are certain things. How about, a skin condition due to a disease? How about rheumatic fever? How about chicken pox? All of these things you get measles, all of these things create a skin condition, right? Those are just some of the diseases. And then, of course, we have skin problems like impetigo, right? So, and just the fifth disease where you get all of those sores from a virus in your lips and whatnot. So and then you have a child who's allergic to everything and eczema and allergic dermatitis. So one of the things with skins, and we're seeing a lot of allergies, um we need to look at foods that they're eating, and we need to look at what the possible allergies could be. Is it a dog and a cat and you have them in the house? It's not a good thing. Or this child loves strawberries but he's allergic to them, so we can eliminate those allergens do we need. So skin tests are really important that we do, and it really could show us any age person what needs to be avoided to keep their skin from breaking down and itchy and eczema and oozy and become infected, because all of those. Now, hair actually tells you what your nutritional status is. It's nice and shiny and grows and thick. We know that that is a person who's pretty healthy, right? Now, the hair can change due to medical treatments. Well, just think about chemotherapy, right? Hair can fall out. That's just one of them, and there's many more. So when we're looking at skin problems, we need to document what we see. And we know skin problems change from day to day, from morning to night. It's just children. So documenting is important. And now we have, this guideline to look at. What was it when, they came in this morning, and this is what I have now, and look at the differences, the size, the color, configuration. Is it painful? Is it itchy? Is it small place? Is it all over the place? Is it localized? Or is it generalized everywhere? And then looking at what does the skin look like around these lesions. One of the ways that we can manage itching, scratching is just the fingernails. Well, that's one of the reasons why we need to keep children's fingernails short. It's not written there, but they don't have fingernails that can't rip the skin off. Children at night will rip their skin off and not know what they've done. Many times these problems with the skin is keep it lubricated with lotions and creams and ointments and using them as the doctor orders them. One of the things with giving ointments, especially ones with steroids in them, remember that stuff does absorb into the body. And I always tell my parents, more is not better. Put enough to get it covered, but don't overdo it. That is just as dangerous. Do you know, I had a little boy who had a rash, came into the trauma room, and he was sort of catatonic. And what happened is daddy put Benadryl rash cream, the Benadryl lotion, from head to toe on this child, and he overdosed on Benadryl cream. So that's just an example to show you, yes, he didn't know. Well, now he does. So there's all different types of words, the vocabulary for this. We have a macular, it's a flat rash, it's like a freckle. We have a vesicle, it's elevated and fluid filled. That's either like your cold sore on your lip or that's chicken pox. Crust is just a scab on it. A papule is raised as a pimple. Pustule is that impetigo, or really nasty acne, as we call it. And then the wheal is a raised, red, irregular mosquito bite looking thing. And then ecchymosis is that black and blue mark, bruising. Now a sty, they hurt, right? I just had one right inside my eye, a little white spot. And all of a sudden I felt it. I'm like, what's going on? And it was a sty. It's also called a hordeolum. And it's something that's the sebaceous gland. It's this duct that gets filled with usually white pus stuff and it will raise to a head. Many times it will open and burst, and sometimes it doesn't. It just goes away. Strawberry nevus, having one on the face is really, uncomfortable for parents. They've got a beautiful child and they think they're ugly because of these things. They can be taken care of. There's all sorts of creams, lotion, hormones, and stuff that we put on. They don't need surgically removed, okay? So there are some too that in time, as they grow, it will go away. So, as nurses, letting parents know these things that it's okay, it's going to go away. If it doesn't, there's some creams we can give. So, look at those big eyes. Isn't he cute? I mean, change the focus on these children, for these parents. Port wine nevus is present at birth, and it's dilated dermal capillaries, means blood type things. And it is purple to pink. And these lesions get darker as they get older and they don't disappear. So it's something that will be there. So some of the types of lesions, cafe au lait, it looks like coffee splatter, right? Yeah, hypopigmentation would be maybe a black person who has white. I mean, remember Michael Jackson? Those type of things. And sometimes the hypopigmented can be associated with tuberous sclerosis, and sometimes the cafe au lait could be the neurofibromatosis. So there's different reasons why it could happen. Butterfly rash, that's lupus, right? Butterfly rash on the cheeks. And it's photosensitivity with that. Scalding skin eruptions, it's usually around the mouth as a horseshoe and it's on the chin. You will see papules and scales on these children. Many times it could be a vitamin deficiency. Skin and rashes are some of the hardest things in children to diagnose, and not every pediatrician can do it. Vascular birthmarks, sometimes it looks like a bruise. It can get better over the years. Hemangioma around the chin could, remember, this is a swelling in a place where the airway is. It could occupy space and it could create airway problems. And then besides that, what about spinal problems in like the lower back? Lower back feeds the lower legs, right? It could create problems, with walking and weakness in the legs. So here we are with another one. Let's see if it's going to go back to the beginning again. A female adolescent has a port wine nevus since early childhood and now has severe acne. She doesn't understand why she's susceptible to these skin disorders and asks whether she has done something wrong. How should the nurse respond and what advice should she give to her? Well, what do we know about port wine nevus? They're born with it, right? There's really nothing we can do with it. And we know children all the time think that if something's gone wrong and they're sick or they fall down, they hurt themselves, they think they're being punished by God, right? That's just part of a child's thought. So, I mean, even adolescents have this in their brain. So, let them know this girl did nothing wrong and it's just something that she has there, and make it into a positive and not a negative. Infectious miliaria, this is your prickly heat. This is sweat that gets moist and creates rashes on them. You'll see the little tiny pin head, little reddened papules, and it can be itchy on these children. A lot of times it's where that heat and the moist and the damp inside the diaper that, you'll see these sort of things. One of the ways that we help decrease the incidence of it is to not have them overdressed. You don't want them sweating, bathing them routinely, making sure that we, dry those skins and change the diapers, quickly. Intertrigo. This is called chafing, and it's again a dermatitis on it. It's due to that sweat, due to urine, during the stool. It could be older children, obese in the folds, all of those things. How do we treat it again? They're in a hot, moist area. Keep it dry and try to keep it cool. Seborrheic dermatitis, cradle cap. Cradle cap is one of those things that parents don't want their cute little girls to have. They want those cute little, headbands with bows and ribbons. And oh my goodness, what's going on here? What is this? Well, all we do is with these children is we will moisturize it, shampoo it, moisturize it, and we'll take a fine tooth comb very gently and we'll just continue to comb it. What they say actually is olive oil or baby oil. Leave it on overnight and then bathe them in the morning. And that adds that extra moisturizing. I think diaper dermatitis is one of the hardest things for a baby and a parent for the baby to get. Every time they urinate or stool, the kid cries because it's open, excoriated skin. And it could be due to anything. Even that diaper rubbing against it causes pain to them. So, why do they get dermatitis? Well, my kids were allergic to Huggies diapers. They could wear Pampers, but they couldn't wear Huggies. Christian was the same. It could be due to foods that these children are eating that comes out on the stool, and then it creates this rash, this opening type of, the skin just gets excoriated and opening. So how are we going to take care of it? Well, yes, you need to keep it soap and water. Well, a very mild soap and water. Just, and we even have those nice little just wipes now that are just water, making sure we keep them clean and dry. And if it's due to a diaper allergy, change it. If it's due to a food problems, we're not going to do that again. This child will keep parents awake at night because it hurts so bad. Acne vulgaris. Acne is an inflammation of the sebaceous glands and the hair follicles. We see this about puberty with all these extra hormones that are going on in there. A comedo is a big blackhead, and it could be when it's open or closed, it's a whitehead. These are the big pimples. How do we take care of it? Well, you need to clean it, but not over clean it. Some adolescents want it gone so bad, they clean their face so much it creates more. So they need to be taught that. Keep those greasy hair products, cosmetics away from them. Again, don't over clean it. And then use whatever they've been given the way that it's been ordered. Usually it's multiple types of creams and lotions and ointments, and to follow it the way that they should. It has to be done as prescribed. And again, as I said, more is not better. Now, herpes simplex. Now, We call them a coleslaw or a fever blister. As soon as I get sick, bust a little fever, I can feel a little something. You feel that little tingling coming up there. Um, Infants can get it, and why? Well, maybe mom had it, and when the delivery, she passed it. She could have had, perineal herpes, right? And, she could be active at the time, didn't tell anybody, and it can be passed to children like that. Or she had it, doesn't wash hands, and again, passed it on to the infant. So one of the things is with herpes, usually it lays dormant. Then it could be stress, sun, menstruation, hormonal stuff, fever could cause it all of a sudden to be reactive. And then it can be as severe as this here. I've seen it even worse. Treatment, we can give oral, topical, sometimes even intravenous antivirals can be given. Infantile eczema. You're going to say infants have eczema? Sensitive skin kids, absolutely. It's one of the things with children is, sometimes we see it more in the bottle fed child. That breastfed mother's giving all of those immunes, antigens, antibodies to the baby, and usually they're not going to get this, the eczema. We know that it is an inflammation, it's hypersensitive, and sometimes it's due to contact with something. It could be the soap, the creams, the lotions, the soap we use for our clothes. They need those hypersensitive things. We know it's worse in the winter because you're drier in the winter too, right? These things can open, become juicy, and they can become infected. Whether, I mean, bacterial, you think's the infection, but sometimes it can be viral. And if it's on the skin, it can go systemic, okay? They also say that it can flare if you're being given immunizations. And, we're talking about immune things, IgG, IgE, all this, the IgE, and the eosinophil levels that you might see when we're having flare ups or worse eczema on these children. So, what do we do? Well, any rash type of thing in children, one of the things always will be to keep it lubricated, to get it moist, hydrating it. There are so many good looking these products that we use today. They're getting better and better. We give them these emollient baths, cornstarch, baking soda, oatmeal. There's all things out there today, all sorts of products. The child, it depends. We tell the parents just keep trying until you find one that works. Bath oil, it keeps the skin moist. And again, putting oil back on their skin after their bath. We don't like to just give corticosteroids for decreasing inflammation, but when it's bad and it's really itchy, that's when we'll use those corticosteroids. If it's open and oozy, they will be giving antibiotics and some anti-itch medication. And again, keep those nails short, right? So ointments need to be cleaned in between each application. As I said, cortisone creams, you got to be careful because number one, you can overdose them and it's a steroid. Number two, we know any steroid masks the signs and the symptoms, the underlying cause. So it's the last thing we'll put on. Figure out the cause and then we'll probably use it. Putting on topical medications after a warm bath, the skin's open and dilated and will receive these creams and lotions better. You stroke the direction of hair, as I said, only use what they tell you to use, the proper amount. In the hospital, we've got those elbow restraints. They can't bend to itch. So unless it's the upper legs they can grab, right? So, but we do use them. And if we are giving steroids, it shouldn't be used with viral infections. Staph. Well, staph is everywhere. We know it's in everybody's oral pharynx, the airway, always. It's there all the time. Some of the things that we see and find staph is in circumcisions. We know staph is in the hospital. That's why we're encouraged always hand washing, using gloves, right? And staph, if it goes topically, can go systemically and cause what we call septicemia or septic shock, which means the kid gets a bad infection and extremely ill. Whenever we see rashes and pustules on infants, we should tell the healthcare provider. And we sometimes will use ointments, sometimes we'll use oral, sometimes we'll use antibiotics intravenously, depending on what infection it is. Now, MRSA, methyl-resistant Staph aureus, is a big deal. It's a lot of times a hospital acquired disease, and we need strict head to toe covering in private rooms with that little isolation carton the outside, and it really needs to be followed. The isolation techniques go to kid to kid to kid to kid. Scald skin syndrome looks like you've burned the child, like you threw hot water and you can see how it's peeling like it's been a big blister that's just popped. It is due to staph again. You'll see it start with a little mild redness, then you're going to see vesicles, and then when those vesicles come off, it's this bright red underneath. And remember, with scalded skin, if it's a true syndrome, these children, they haven't been abused, but I've seen children that has been burned with hot water or oil, and it was abuse. So this is one of those cases where you don't think that it's abuse, but you don't know. And remember, as nurses, our job is to protect children. That is first and foremost. We are there, we are their eyes and their ears, and we need to protect them. Once you've seen a child abuse case, I hope you never do, but if you do, you'll understand what I'm saying. I've seen some horrible abuse, but I know today, because they've been reported, these children are in a better situation. Impetigo. I got my grandson 2 years ago, and mommy told me behind his leg that the kid had itched so much that he ripped the skin off the back of his leg. And I looked at it and I went, I don't think this is him itching. So I had some good antibiotic ointment. I had that good old Bactroban in the house. So I put it on him. Well, I'm telling you, this thing got spread so quickly. It was so painful. It was the ooeyest, juicy, scab, crusty infection I've seen. Highly, highly, highly contagious. So this child, I washed my hands, I used gloves, and because he couldn't go to school with it because he's contagious, he stayed at my house. So I had to be very careful with him. They put topical antibiotics on it. After 3 days, it healed slightly, but he needed oral antibiotics, and they usually put them on Keflex. And that's what we did with the topical Bactroban, and he cleared up. It is usually staph. It can be strep too. Now, fungal infections. Fungal infections are something that you're going to see that You're going to say, well, why is that a fungus? Well, sometimes there's white spots, there's, round spots, and you're going to say, is the a fungus on it? So fungi are, something that can be treated. It can cause hair loss, tinea capitis, alopecia, or hair loss. It can cause this tinea corpus, which is this little oval area of inflamed skin, and the center's clear on it. How about tinea pedis? Isn't that what we call athlete's feet? That is also a fungus, and it itches like crazy. And then tinea cruris, which is um, men that are in sports that use something to hold their privates good, and it gets hot and sweaty, and it can cause what we call jock itch, which is a fungal infection. So pediculosis, lice, could be head lice, body lice, pubic lice. My little girl with hair so thick and so long in kindergarten got it 3 times. It is usually these we can treat just with shampoo and combing them out. Pediculus capitis is head lice. Pediculosis corpus is body lice. And then pediculus pubis, which is pubic lice. Usually the pubic one is due to, sexual activity. But the survival of these lice, they lay eggs and they keep laying, more lice are formed. So we got to kill them and the eggs also. Scabies. A lot of times you hear scabies was caught because you were in a hotel and the mattress wasn't clean. That's what I've heard a lot of it from. It's caused by the female mite. It buries into the skin and lays eggs. You'll see it in those little warm spots between the toes and the fingers. And it's at night when it's dark, you start to itch, 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 itch. It's in a bigger person that has folds. It's going to be in there again, moist and dark. And again, itch. It could be personal contact. It could be that, that mattress. And what we do is we put permethrin on it. And we put it on before they go to bed at night and wash it off in the morning. It's usually 8 hours later. Now, if a child has scabies or anybody in the house, the whole family should be treated. It's that contagious. So a mother comes to the clinic with her 1-year-old child has visible infantile eczema on his face. She remarks that she can't have this picture taken because of the visible lesions and asks how long should they last or what can she do to eliminate them? What would be an appropriate response? Does anybody know?
Can you do like an oatmeal bath?
Well, when you have infantile eczema, absolutely. This is the one that we're going to put cream on. We're going to use mild soaps, keep away from perfumed anything, and moisturize, moisturize. And then if they need any medications from it, you can see here is we don't know. We think it's caused by an allergy. And usually symptoms sometimes come when breastfeeding stops, because what mommy does is give those, antigens which can stop it. Sometimes with the itching, they might put them on some antihistamines with it. And again, I'll always say it, it's never in these PowerPoints, but cutting the nails is a big thing for this. So burns, you know, Burns are usually something in younger children that's an accident. They go up to the stove, they pull down a handle, or they pull a cord with something. I had one brother who actually burned his whole arm. There were seven of us, so if only one kid got a burn, it wasn't really that bad in my house. And they were six boys, so they were a handful. But one of the things with burns, as I said earlier, you've got to be careful. Is it a abuse or it was genuinely an accident? We know a lot of times it happens in the morning when the parents are running around trying to get kids for school, or it could be after school. Kids are trying to make a snack after school and things happen. Types of burns: thermal, chemical, electrical, and radiation. Now, thermal is due to a vapor or liquid. It could be a boiling pot of water. You put your hand over the steam and you burned yourself. Chemical could be due to a corrosive powder or liquid. You touch something that was caustic, and it caused it. Could be, even like stuff that you use for pest control or bleach, or some of those things can cause it. And electrical, these kids like to take cords and put them in their mouth and chew them, and we know what happens. Burns in the mouth you would see there. And then radiation, I mean, that would be the child who is getting treatment of some sort, because even radiation under observation, it still can cause a burn. So there are different areas, and it's called the body surface, and it talks about how much of the body was burned, and it works to a formula in order to give fluids. When you burn, you're burning fluids off, and that replacement is your biggest thing with that. And then, of course, prevention of infections. So that's the whole table there. Now, just to know that there is areas. This is not something that we're going to say, all right, you're burned here, here, here. How much percentage is it? No, we're not going to do that to you. What you need to know about burns is that fluid replacement will be needed because it's burning fluids off of them. It could be in the skin. The biggest concern in burns, if anything around the face or trunk, be concerned that they inhaled some of the burn. And now you have to worry about airway. Smoke inhalation, airway. And remember, with those things, it could be a delayed response, okay? So airway with burns is always priority. Children have thinner skin, so it burns deeper. We know that because of the fluid that's going, children can be going to shock. And then with resuscitation, giving them fluids to replace, they can go into heart failure. They're not ready for this burn off and then replacing these things. We know that it loses heat, it loses electrolytes and fluids. When we're doing later on and recuperating these children, high protein, high calorie. Protein aids with, the skin to help it heal, and muscle, okay? And again, scarring can happen with these burns. So one of the things that is focus on the surgeons is to make sure that the skin is in a manner where there's not going to be contractions. And they do a lot of dressing changes and exercises. Sunburn. I live in South Florida. I mean, it's always, you go outside, you don't realize it, and you're burned, okay? One of the things with sunburn, and it's highly recommended, especially with things like lupus, making sure that we keep the skin with suntan lotion, that we limit the amount of, time in the sun, because it can cause, again, burn, blistering, and fluid loss, right? So one of the things we want to prevent is that. Zinc oxide, titanium dioxide, that's that white stuff that you'll see. And some of the young kids who burn really hard, they'll put that on their noses to help. Now, I used to live in New York. I used to go snowmobiling in 18 below zero. So I know what it is to be really, really cold. One of the things that can happen if you're out there too long and you're not prepared is frostbite. And frostbite is where the skin gets so cold that the blood stops flowing and the skin and tissue dies. Chilblain is a cold injury with that erythema, that redness, and vesicles and ulcers happen because it's such constricted. Cold constricts the tissue so much. Now, when you are with a person, child, that has been frostbit, they're outside, they're cold from head to toe, they need to be warmed up, okay? It's going to be painful, believe it or not, because now they're starting to feel those hands and the feet and the nose and the ears, that they've never, they didn't know. So, and as I said, it causes death of the tissue. So again, make sure you address that pain because it hurts. So the school nurse for an elementary school must prepare an educational program for the school children on emergency responses for a burn injury. How would the nurse educate the children? Well, this is elementary. What are you going to teach children about not getting burned?
Not to touch things on the stove.
Absolutely.
Watch your temperature of the water. Don't let the water be extremely hot.
Absolutely. If I ever see children, I've seen one sit in a tub and burn their perineal area. I'm like, you need to go to that water heater and turn that temperature so it's not so hot. That was the cause of it. Again, and if they're heating things up, elementary, sometimes they'll come home, they're alone, right? They're latchkey kids that they might put, a can of SpaghettiOs in the microwave, making sure before they put a lump in their mouth to check for hotness. So there's so many things that we could say here. So metabolic system, endocrine system, there are several things with it. It's endocrine does affect the nervous system and the endocrine system. And we know it all has to do with their metabolic process, which means the endocrine system gain is about their weight, their height, and maturity and how they grow. And even the thyroid's all about their cognition, how smart. So when you see a child who is tired, not eating, a failure to thrive, which means they're not gaining weight the way they should, they're vomiting, and they've got a big liver, this could be something that's going on with these children. One of the things about these children is, let's say a kid is born and we haven't diagnosed that they're, let's say, endocrine, a thyroid problem. They don't have enough thyroid hormone in their body. If you don't have thyroid hormone in the body, two things happen. Cognition, they're not going to be where they should. That's why we do all of these assessments on their growth and development. Are they turning over? Are they lifting their head? Are they grasping? All those things is going to measure cognition. The second thing is going to be all about their weight. Are they gaining weight? Those are the two things. So, unexplained mental retardation, developmental delay, even convulsions, sometimes hormones, you don't have them, can cause these problems. And then this odor, This could be DKA, right? This could be a blood sugar problem that goes on. So you're getting all these little symptoms, and what do you need to do? Well, we can do an x-ray if something is bothering them, but it's more of that doing those blood tests. Now, at birth, we do those PKU, those little circles, right? We're looking for metabolic issues. Now, if we're seeing that there's a problem, constipation, or we seeing that there's a problem that at 1 month they're not doing what they should be doing, we're going to be doing, more metabolic things. Also, chromosomal. We know there are some chromosome syndromes that you will have delays. If we know what it is, we'll do a tissue biopsy, we'll do thyroid functions, ultrasounds. Is it large? Is it hypoplastic? And a lot of times we're going to see things excreted in their urine, so a 24-hour urine. Now, Tay-Sachs disease, it all has to do with metabolism of fat. And the fat accumulates on nerves. So there's not a lot of impulses that can go. So physical and mental deterioration. This is usually in the Ashkenazi Jewish population, and it is passed on. It's a recessive trait on it. These children, you don't see it at first. So about 5 or 6 months, all of a sudden, they should be holding their head up and turning completely over. All of a sudden, they're just not doing what they're supposed to be doing. If it continues and we don't know, it's going to go to the point where they're blind and mental retardation, and it'll be permanent. And most children with Tay-Sachs will die before 5 years old because there's really no treatment in it. But one of the things in the treatment is alerting parents in case they want another child, seeing what's going on and doing those screens. Mention a little bit hypothyroidism. This is the one where you don't have enough hormones, and we know it controls metabolism, which means are they growing the way that they should? A lot of times they're born congenital hypothyroidism, and one of the symptoms they see is constipation, believe it or not. No stool in the first day and a half, nothing. Usually infants, they're born and they're stooling at birth, right? That sticky black greenish stuff. But you're going to see that they don't, and they'll be testing for it. Now, later on, sometimes the hypothyroidism is acquired. Now, older children, late school age and adolescents, there is a autoimmune one called Hashimoto, lymphocytic thyroiditis. This is a child, and this is my daughter-in-law has Hashimoto, and she requires for life these thyroid hormones. You've heard of things like thyroxidone. You've heard of, what else is a thyroid hormone? Just the normal ones that are out there. I'll think of it as we go on. So remember, sometimes these children get too much, too little, and these children, once they get placed on their therapy, they grow better, cognition, they will be better. Now, one of the things, if the thyroid stops producing what it should and they're older, usually that cognition is not going to be as prevalent as it was in the young children. Young children really need their thyroid hormone. Now, screening tests, well, that, little spot test that we do at birth, we can see it there, okay? All children today at birth are tested, okay? It's one of those recommendations because children can't tell you how they feel. So we have to, because of the incidence of it, making sure that we're testing on them. Now, if everything's down Hypo. This is a child, an infant who's very tired and sluggish and sleeping a lot, right? Their tongue gets big and they start because of that when they're breathing, okay? Now, just like adults, skin is dry, their cold intolerance and constipation, and their hair is dry and brittle. The difference with children is growth, right? And cognition. In older people, it doesn't make the difference, but you can see those similarities. Again, in children, we need to treat the hypothyroidism. Synthroid is the name of the medicine I was thinking about. Usually is the one that they do. And again, we need to give it so they don't have cognition, permanent problems, and the growth. When we do these synthroid or these thyroid hormones, they need to be monitoring those drug levels. And one of the things with hypothyroidism, that therapy can stop further mental retardation. But if it's gone on too far, that cognition, that delay will be there. So it is important. And we do now, as I said, at birth, we do check these things. So what do we see? Temporary reversible hair loss. They're, insomnia. They get aggressive. And you're going to see that their schoolwork isn't going to be what it should be. And again, any hypothyroidism, you don't have a hormone, it's replacement for life. Now, too much thyroid replacement, and this can happen. You forgot you gave a dose and you gave a second dose to the child. Well, before you were down, everything was low, right? You're tired. Now, you give too much hormone, everything goes up. It's almost what we call like a thyroid storm. And that causes rapid heart rate. That causes that tightness and dyspnea, tightness in the chest, dyspnea. And they get irritable. They don't know what to do. They're burning calories, so they have a weight loss, and part of it is sweating. Now, conversely, you're not getting enough thyroid replacement. Everything is down. Fatigue, sleepiness, and look again, constipation. So parents need to be taught, if they start seeing the kid going hyper, heart rate, not sleeping, sweating, there's something wrong. They probably need to do a drug level on that child. Now, diabetes insipidus. Diabetes insipidus has nothing, absolutely nothing to do with blood sugars. Diabetes insipidus is all about fluid. It's the posterior gland, and it secretes fluids that keeps your kidneys flowing the way that they should. In diabetes insipidus, it secretes too much diuretic hormone, and you urinate. You see, it's not enough of the vasopressin, which is an anti-diuretic hormone against urinating hormone. If you don't stop the urinating, you're going to urinate too much. Okay? So, besides urinating, you're thirsty. So polydipsia, polyuria. Okay. Another thing that happens with the pituitary is what we call growth hormone. And that is the other lobe, the anterior lobe of the posterior. And it all has to do with too tall, too short. Are you a dwarf or are you too tall? So again, there's two hormones that come from posterior gland. One's with growth, one that has to do with fluid balance. Now, the parathyroid is not what the thyroid gland does. It has nothing to do with, synthroid and growth. What it has to do with is calcium. Parathyroid gland secretes enough calcium that is good for your bones and for your muscles. And if you have too little, your muscles are flaccid and don't work. If you have too much, it's hyper, you're like tense, that you can't control your muscles. The other gland, which is endocrine, is adrenal. And adrenal has to do with steroids and it has to do with sex steroids. There are two types. There's Addison, which is not enough. And the problem with the sex steroids is with not enough in Addison's, these children are born and they don't know if they're boys or girls. They have characteristics of both. Cushing's is too much steroids. Usually that's when you're given steroids like prednisone and it's too much on the body. And then you have other problems, the big round moon face. Now, diabetes mellitus, this is your blood sugar, all about blood sugars, all about the pancreas and secreting insulin. So what happens is with children is the pancreas doesn't secrete enough insulin, does not digest carbohydrates, so there's sugar that's put into the blood system. Now, in adults, they say fasting blood sugars of 100 after 8 hours and no food. In children, it's 126. They give it more. Hemoglobin A1C in an adult, they say 6 is your pre-diabetic, right? In children, it's 7. So those are the differences there, okay? So when the body can't have sugar because it can't digest it, what does it do? Well, what it does is it's going to start eating proteins and fats. And the blood sugar is just going to be everywhere in the body, and you're even going to see it in the urine. When it eats the proteins and its fats, the byproduct is called ketones. And you're going to see ketones in the urine. So diabetes, DKA, diabetic ketoacidosis, is high blood sugars and a lot of proteins, ketonuria in the urine. So with children, we've got to make sure that they are getting the nutrition they need and preventing complications. And many of the complications are just like adults. Blindness, problems with the kidneys, neuropathies, circulation, all of those things are just like adults, right? And with children, we've just got to make sure we keep them the way that they're acting normal. Keep them in their sports, just giving them snacks, monitoring their blood sugars really, really well. Now, a child who has been diagnosed with diabetes usually will come in with the symptoms, the 3 Ps. Now, diabetes insipidus is 2 Ps. They're not hungry because that has nothing to do with food. Diabetes mellitus has to do with food, so it's 3. Polydipsia, polyuria, polyphagia. And all of a sudden, they're going to see a weight loss and their skin is dry. Now, they're not eating sugar, it's not being absorbed. So now they're lethargic because they don't have sugar, no energy, they're weak. And again, it'll be that weight loss. And in adolescence, in the girls, they can get yeast infections. As I said, they're going to have glucose in the urine, proteins in the urine when they get really sick. They'll have hyperglycemia because it's not being broken down, and they're using that protein and fat. So again, that fasting Glucose is 126 and the glucose tolerance is more. What they say, look at this, a hemoglobin A1C on children, value 6 to 9 is good. And in adults, we don't want them above 8, do we? So you can see that there's slight differences with children. I'm not going to go over this question because it's getting late and you can go to the thing and look at it. I just want to get you your information that you need. Now, diabetes can be treated with insulin. Children who get diabetes at a young age are type 1, which means they're going to need insulin. They never turn into type 2. Once diabetic type 1, their pancreas never starts working again. They're always type 1, okay? So DKA is when blood sugars, I've seen 1,000 as one of my values. I saw their proteinuria 4+, glucoseuria 4+, and the ketoacidosis makes those ABGs. Now, a normal ABG pH should be 7.35 to 7.45. That child who had 1,000 as a blood sugar, he was in DKA, his pH was 6.8 and he made it. And that is very, very dangerous. In ketonuria, these children are just not themselves. That altered level of consciousness, they're nauseous, they're pale, and you can smell the sugar that's elevated. They breathe sugar. It smells like rotten peaches. That's exactly the smell it is. And you're going to see again that decreased CO2, which causes the low blood gases and the ketonuria. It can start quickly or it takes, a while to get there. So what is our goal? Well, keep them with a good diet, make sure they're doing their insulin. They need to be active. Don't stop them from sports, but you are going to make sure they have snacks and they monitor blood sugars before they start. Okay? Education is very important and making sure that we understand what these children and families can afford. Those pens that you give are great. Not every family can afford them. So this needs to be taken into consideration. And you don't know this or think about it, but there is pork insulin. There are religions that don't give pork. It would be against their religion to take it. Make sure they're monitoring their glucose. They know how to do their food groups and their diet. If they're on a pump, they know how to use it. Kids do well with all those pumps. Again, just like adults, skin and foot care, they will get ulcers. They can lose feet and toes. Infections, remember, they're going to be longer to come back from them. Stress, emotions affect them, checking their urines, and if they're traveling, to keep that insulin safe in a cold pack and get it in the refrigerator when they get there, and make sure they have snacks, okay? Very important. They do grow well if they're given enough of the right type of foods. And there is the way to break up the foods, and there's groups that they're given. We work very closely with a dietitian with these children. One of the things in foods today, a lot of them will say it's diabetic. Make sure that they're reading labels. We need to teach them, making sure that they understand increasing fiber. We will help them bring down their glucose naturally, okay? It slows the absorption. Insulin. Children do give their own, and I've watched it. They do well. I've watched them do their own blood sugars. I've watched them readjust their insulin pumps to give boluses. So when they're able to, let them use it. Insulin. Clear before cloudy. So you pull up regular insulin and then you pull up the NPH. That's an important concept. So remember with insulin, you've got to know when it's going to be at its peak. So that, let's say you're giving an insulin and you gave regular insulin and breakfast isn't there, that you know to go back to check that child, make sure they have something to eat because of the peaks. And children and the parents need to know that also. What's great about those pumps, they stick a needle in, and I had one nursing student who worked with me and said she used to change it every week. So it's one stick instead of sticking all the time, which could be 4 or 5 times, right? Insulin shock is when there's too much insulin, blood sugars are too low, and it could be due to exercising and didn't take a snack, not eating enough, or not giving insulin the proper way. And we need these children and people to know what we need to do. These children, if they don't have a good glucose, they're going to become irritable, they're going to become irrational, not acting the way they should. They go pale because they're not getting sugar. Their blood sugars are low. They're going to feel weak and hungry and nauseous. They're going to sweat. So, what do you do if you see this occurring? Well, all signs and symptoms of hypoglycemia, get them something: honey, sugar, orange juice, milk, something. But as soon as we can, give them something with protein. Like a turkey sandwich is great. It's good protein. Now, we give them oral when their condition is they're awake and alert. But if they're not awake and alert and they're, really not their level of consciousness, you don't want them to eat anything. They'll aspirate it. That's when you give glucagon. And that's a big thing of glucose. Samoji phenomenon is what we call rebound hypertension, and as they get hypoglycemic during the night, and the child needs to have just less insulin. And then there's dawn phenomenon. These are two things that were given to you in pharmacology. I used to teach it, so I remember teaching about it. It's that early morning blood sugars that you can see. So Samoji and dawn are two of the things that you see in children. Now, type 2 diabetes, usually it's more of your overweight children. And this, what we would do is recommend diet first. They're not working. These type 2 older children can take oral medicines. Sometimes they do oral with insulin, but whatever it is to take control. So it's more about diabetes, and let's go into communicable diseases in the last chapter. So here are your terms. Communicable diseases, it's from one person to the next. Incubation is how long before the contact till you get it. Like, for instance, chicken pox, right? You can have a child who's been exposed, and it's not till 5 days later that you see the symptoms. Prodromal is the time between the earliest symptom and the appearance of a rash. We call that a lot with chickenpox, that one. Vector is the insect or animal that carries and spreads the disease. Ticks, right? Lyme disease. Pandemic, that's COVID. Epidemic is just Miami, just New York, just an area. An opportunistic infection is caused by an organism normally present in the environment that the immune suppressed person cannot fight. These are things like your staph, right? They're there. Most people can fight them, and there's many who can't. And healthcare associated infection, that's your MRSA, right? And there's a couple more of them, but it is spread usually in the hospital setting. So the virulence of infection, host resistance means the person is resistance is influenced by what? If you're younger, you have more of an immune against. You're older, you're going to have less. Sometimes it's male, female, genetic. Nutrition always makes a difference. If you're eating properly, you have more, resistance against these things. If you're not, your body's defenses are down. Physical and your emotional health does make a difference in it. Phagocytes in the blood, that's your immune system. If they're there, it can fight. And then if your skin is intact, there's no opens, no burns, etc. That can keep down. And then, of course, you need an immune system. So types of immunity: natural, acquired, active, and passive. Natural, you're born with. Acquired is that you either had a disease or you got a vaccine for it. You're immunized against it. Active immunity, you made your own. And passive immunity, it provides an antibody to the person, but it doesn't last long. I mean, there are things, even influenza, we have to take it every year, right? Because it doesn't last or it's changed. Preventing spread of infection, aseptic technique, and standard technique is usually always considered universal, which is usually hands. And if you're going to be sprayed, put something on to cover that. Transmission-based precautions are always designed against what is the organism. Is it E. coli or is it respiratory? And that's what we'll do. So airborne meningitis, something that you would put a mask on, and they need to be treated for 24 hours before we can, be without this type of protection. This is TB varicella. It's another one. We do put those N95 masks on. That negative pressure room gets the air from in the room, goes outside through a filter, doesn't come back in, because things like pertussis, TB, varicella, you put it back into the system, other people in the hospital, other children will get it. Contamination, when we do contact. This is like stool. This is like secretions, respiratory secretions. Here's some names: CRE, RSV, MRSA, VRE. These are all things. The VRE and MRSA are the ones that are hospital transferred there. Remember, with contact, you do gowns, gloves, everything. You need to remove it. And remember, always hand washing before and after. Droplet is when we have it's in the air, coughing and sneezing. And only regular masks are good for this one. It's not as serious of varicella or TB. So again, you go in, you put it on, before you leave, you take it off, you wash your hands. Hand hygiene, sing happy birthday. That's what we tell the kids, right? There are so many vehicles to clean your hands today, all these alcohol things all over the place. There's no reason for our hands to be dirty. We used to have artificial nails in the hospital. We don't anymore because it harbors bacteria in there. So we don't use them anymore. They're looking at the gels too, because yes, they're pretty, but we're spreading infection to our patients. So educating family, number one, it's always hand washing. Making sure that they know immunizations and the importance of them. Food storage. A lot of parents and cleaning areas in between foods and raw meat and all of these things should be looked at. Looking at like bathrooms that, don't have like a single sheet of paper, that there's something that everybody uses. This just giving infection from them to me and somebody else. Insects, we know insects, ticks, those things can cause a problem. They don't like sandbox because it does harbor, a bunch of different, like ringworm, roundworm, pinworms, those things. And again, cutting the nails. We went over the types of rashes earlier, so there they are again. One of the areas that the government looks at is something called healthy people. I've actually done quite a few papers looking at healthy people and what they're looking at. And it promotes some sort of health program. And what the one for 2030 is immunizations that we should promote it for our children. Vaccines, we know that they are used to prevent disease. Once you have it, it does not treat it. And once we have a vaccine, we do have an immunity now, okay? Allergies, toxicities, there are things in vaccines that some people can't get. Hepatitis B has some sort of yeast in it. I can't have it. It's an allergy to it. So these are things that we must consider. Giving in immunizations, we need to watch those children for a minimum of 20 minutes to make sure there's no allergic reaction. And you can see here in another eggs, you can't have influenza, MMR, neomycin. These are things that we need to know and look at before giving immunizations. Contraindications to immunizations, you're immunosuppressed, or you're in therapy that renders you immunosuppressed. You don't want to get an immunization, which could cause more problems. Sometimes in pregnancy, they say yes, give them, and sometimes they say no. If we are with any infection, we'll never take the immunizations then. And any person immunosuppressed, it also includes those children or adults on steroids. Steroids do render you immunosuppressed. And the other thing we need to be careful with is children that have a history of these big fevers after. They have to look at the benefits versus the risk. Now, bioterrorism, pediatric children, one of the things about bioterrorism is, the child, the family. If the immune system, especially on younger children, cannot tolerate anything like that. And problem with, let's say they come up and it's anthrax or something crazy of the sort, which could happen. Remember, children don't tolerate it as well. And the safety of these medications, we don't use it all the time. So do we know how safe it is? Now, living in South Florida, I'm always in emergency preparedness for hurricanes. You should always have enough food, water, pet food, warm blankets, etc. If you have a battery powered radio, it's great. Children should be ran through a drill. Let's say there's a fire in the house. I remember when I was 10, there was a fire in my house, and I remember I knew exactly what to do. If there's problems like with the hurricanes, having people out of state checking up on you, because there was times where all of the telephone lines went down, right? And children should know their phone numbers and who to contact. Remember, children have a larger proportion of surface area and they can be hit harder. They have problems with their lungs post-hurricane. Kids are coming into the ER with asthma attacks because all the stirring of all the stuff with all that wind, right? And they're closer to the ground, right? They're getting more of that dust up there, and we don't think. And, they do have immature immune system, brain, blood barriers, etc. sexually transmitted problems. Yeah, yes, adolescents will have sex. Yes, they can still get sexually transmitted disease. It can come from the pregnant mother to the fetus. It can be also in children come in and have sexually transmitted disease, and it could be abuse. And again, we as nurses need to make sure we take care of that. Contaminated needles are a big thing. Where do you dispose of them? If you have needles at home, what do you do? Being careful. And these sexually transmitted infections, there should be some reporting system to the local public health because it could be an uprising that needs public intervening with it, okay? And if we know who it is, they need to be tested. As a nurse, one of the things dealing with all of these sensitive subjects at times, sexually transmitted diseases and whatnot, make sure that the parent or patient, your children feel safe and they can talk. You know, they're going to tell you some crazy things sometimes. Be non-judgmental. Let them get it out and give them privacy. Let them ask questions and listen, right? And see how smart they are and how they're going to understand instructions the best. HIV and AIDS, it happens many times. It's mom giving it to the infant. I had a mother who had triplets. One is AIDS, one is HIV, and one does not. And this was at a clinical site that I worked at. With HIV, it's a virus that makes your whole body weak, so there's failure to thrive. All of the lymph nodes will be elevated, they'll be chronically getting ill. Anything with yeast, thrush, that PCP pneumonia is the big respiratory thing. Herpes, any virus, CMV, cytomegalovirus. Treatment on any virus, they are going to treat antiretrovirals. At birth, they're going to be given, when they know mom has HIV, antiretrovirals to try to boost their immune systems. And we know there's no cure, but we need to keep them in their immunizations. So as I said, it was a huge, huge PowerPoint today with a lot of information. My voice made it. So thank you for your patience. I will send you the cahoots. You do have it. Again, I'll send you a message for Thursday, 5 o'clock. We'll do some sort of review. Anybody wants to come ask questions, come prepared, and I'll be there to help you, guide you through it, and help you understand, start you to think a little more.